And if you go to the west, to the left, you've got the border with Mexico. Latin America actually begins in the United States and continues way far down south to Antarctica. There are 3 Latin American countries with research bases in Antarctica, and the Kiwi will know: Brazil, Argentina, and Chile. By the year 2030, the United States will have 150 million Hispanics. It's just a matter of not if, but when the next American president who will be elected is not a Latino. It's inevitable. You're looking at an area where in Central America, you've got Mexico, you've got Belize, which speaks English, you've got Guatemala, you've got El Salvador, Honduras, Nicaragua, Costa Rica, Panama. That's Central America. Then you've got the Andean countries of Venezuela, Colombia, Peru, and Bolivia. And then further down, you've got the Mercosur, which consists of Paraguay, Chile, Argentina. And then you've got this big landmass called Brazil. And of course, the 3 Guyanas up here. I'm from this one, formerly British Guyana. Next door, you've got Suriname, which speaks Dutch. And you've got Cayenne, French Guyana, which is an overseas department of France. They launched the Kourou rockets. And then you've got the famous West Indies, and I need not talk again about cricket, because you know all of our cricketers: Chandler Paul, Sarwan, Rohan Kanai, Viv Richards. I think when I talk, if I have to tell someone where I'm from, just say the West Indies and they know. By the way, Guyana has produced the best cricketers in the history of the West Indies. Clive Lloyd, Lance Gibbs, you've got Sarwan, you've got Chandler Paul, and I mean, I think you know them better than I do. But when you look at Latin America, with the exception of China and the countries of the Middle East, where you're seeing real economic growth, India slowing a bit, we have double-digit growth. Yes. In Chile, we are approaching 10.5% growth per annum. Peru, it's 11%. Colombia, it's 11%. Panama has already gone past 10%. Very few places in the world, and Brazil already past 8.5%. Guyana, 8%. We've been having this growth, as well as Suriname, because of commodities. The Latin America of 20 years ago and the Latin America of today are 2 vastly different worlds. In less than 5 years, Carlos Slim emerged as the world's richest man. Tele-density in Latin America is not as high as India, but the average revenue per user would be something even Bharti Airtel would love to get their hands on. Every year, Carlos Slim's wealth increases. We have more and more people going online. In June of next year, Brazil will host the World Cup football. In 2016, Brazil will host the Olympics. The place other than India with the second highest number of young people in the world is Latin America. And if you're not in Latin America today, do not bother to come next year. It's too late. Last month, we had a visit, 2 months ago, of Xi Jinping of China. And Xi Jinping, in less than 1 week, tied up $300 billion worth of business and committed $150 billion in cash to Latin American infrastructure. You have 5 million Indians living and working in Latin America, India's children, but we don't see India. Why? These 5 million Indians can deliver 26 votes for you at the United Nations when you're ready to become a permanent member of the UN Security Council. With all due respect, India has done a miserable job at courting our own children, and the Chinese have come in, with all due respect to them, and they have taken over this place. However, the Latin Americans have reasons to be concerned. China wants commodities, it's going to give you plastics, but if India came, India can bring knowledge, technology, and at the same time a humanitarian element to its engagement. And I think the whole essence of Gandhi puts India at a very senior moral high ground. When you look at a country like Brazil, most people in Brazil that have access to good health care are in the very south of the country, in places like Rio de Janeiro and Sao Paulo. But the future of Brazil is not in the south, it's in the north, the vast Amazon. This is where Brazil is focusing to become a major economic superpower in the context of BRICS. However, many people walk as much as one day from in the Amazon jungles of Guyana, Suriname, French Guiana, and northern Brazil, and Colombia and Venezuela, and even Peru to get to the nearest hospital. One day. Some people have got to go up rivers and streams, brave the dangers of malaria, anacondas, jaguars, drug traffickers, gorillas, you name it. So what we have done successfully, using Baptist Hospital in Miami as an example, and through the Pan American Health Organization, we have a number of satellites to provide connectivity into the vast reaches of the Amazon, and these little rural healthcare facilities that serve the most remote communities where we don't have anything like a proper road. You can only get in there maybe by the best Canadian bush pilots on these Cessnas, very inaccessible territory. We're using Skype to allow doctors to do remote diagnostic assessments. And based on what they're seeing and the patient's response and what have you, then a decision is made whether to immediately evacuate them by air or if a rural health corps can assist them. And the United States has done a phenomenal job with the United States Peace Corps in going into these remote places. You've even got a Canadian organization called Operation, I think it's called Project Rally International out of Toronto, that's done a lot of work. So that is the whole thing of being in a country where you don't have a lot of physical infrastructure. So you have to develop and depend upon satellite linkages to give them access to use Skype and other means of modern communications. And of course, you do have hiccups if it's raining and it's a rainforest, it rains a lot. However, having said that, people who have got access to health insurance throughout Latin America, governments are paying, private insurers are paying. Do you know where they have to go for specialized medical care? To Miami. And when they get to Miami, the United States healthcare system is making a killing. So what we need in Latin America is not to send people for the north to get health care that they can develop locally with the help of a country like India, and especially an institute like Apollo. I throw the challenge to Apollo hospitals to join me in establishing yourselves in Latin America. If you want to do it, I will give you the land tomorrow. We've got land. We've got we've got many capable people there, and I think India can definitely be a major force for human development and for improve and modernize healthcare. And I just want to show you what we are going to be doing now in terms of connectivity. We're building a new undersea cable that connects Vladivostok to China, to Singapore, to Chennai, to Mauritius, to Cape Town, to Fortaleza, Brazil, and to Miami. The landing partner in India is Tata Communications. In China, it's China Telecom. In Singapore, it's Singtel. In South Africa, it's MTN. In Brazil, it's Brazil Telecom. This is a 34,000 kilometer undersea cable. And for the first time, the entire Southern Hemisphere will be linked. You'll be able to send information in real time between India and Brazil and Latin America. This cable is landing at 100 terabits per second, can be upgraded to 253 terabits per second. I don't think you're ever going to see something like this again for a long time. And the gentleman got the...
Mr. Singh, you got 1 minute to go.
Yes, okay.
Time's is up, actually.
If you would just allow...
I don't think we've got time.
Okay. Well, what I urge you to do is get to, you can do bricscable.com and see what's happening. But Latin America is a place where there are opportunities and it welcomes you. Thank you.
Okay, thank you, Mr. Singh. Okay, next we do have my co-chair, okay, Lord Nigel. He's going to bring to you about triple gain, how patient engagement, job redesign, and the technology will transform.
Sitting there a very long time listening to this, so I'm going to try and be really very quick. I'm going to widen the debate out, however, because what I'm basically going to say, the simple argument that to get at the best out of the IT revolution, we also need a revolution in what staff do, and probably more importantly, what patients do. And that's the real other opportunity which we need to talk about. I've only got time for 3 stories, and they're 3 true stories. The first one is about that revolution in what patients are doing, patients and communities. It's interesting because I think, can I just check that people can hear me on this microphone? Could somebody at the back wave to me? Good, nice to see you, and glad to see you're still awake. Thank you for that. But the point I'm really trying to make here is that patients, as people get better educated around the world, as opportunities grow, as technology grow, people are able to do much more for themselves in all kinds of different ways. We see this in development processes in poorer countries, where one of the most important thing to do is to educate people so that they start to look after themselves rather better. We see it in rich countries. If you happen to be a diabetic, who does most of your care? You do. If I look at my father, 90 years old last year, he has a lot of care. He has a lot of carers. Some of them are professional. Some of them are neighbours. Some of them are friends. A lot of it's done by himself. It's a different world we're moving into. Now, if those are simple examples, let me give you a much more surprising one. I was recently in Sweden, and I visited a hospital in the centre of the country, and I went to the blood transfusion unit, and I discovered that most of the patients were transfusing themselves in the unit. And when I say transfusing themselves, they actually may be on a regime where they needed 3 transfusions a week, but they had a swipe card. And they came in when they wanted to, and they hooked themselves up. And maybe it was in the middle of the night. And actually, blood transfusion, as people will be well aware, is one of the most debilitating experiences if you're on 3 times a week regime and you've got to fit in with other people's timetable and all the rest of it. And this had all happened because a Volvo engineer in Sweden had said, I know about hydraulics, why can't I do it myself? And you know the result in that particular case? Patients were then trained and given the choice, 60% do it. It's less costly, there's greater patient satisfaction, because of course, they're highly motivated to do it well, and there's no cross-infection. It's a very powerful story, and you start to think, well, what else can patients do if they're unable to do it? My second simple story takes me to the UK, and to something that we did 2.5 years ago, called the Whole Systems Demonstrator. Some of you may have seen it. It was written up in the BMJ. It was a randomized controlled trial of 6,000 people, 3,000 in the sample, 3,000 in the other side, in the trial itself. You know what I mean. And what happened is that those people were chosen at random, and the 3,000 who were actually in the trial itself were monitored at home. They were given equipment to monitor themselves at home and the ability to telephone up, ring up, contact their GP or the hospital or whatever whenever they needed it. This ran over a period of 18 months. At the end of the 18 months, the results were startling. Not only were the people who were monitored at home had far fewer hospital visits, either as inpatients or indeed to attend A&E or any of these sort of things. In addition, they were less costly, and you'd expect that probably, but the one that really startled researchers was there was 20% reduced mortality. Now, there's a lot more work that needs to be done to understand that study, but it was a randomized controlled trial. It did involve 6,000 people. It demonstrated very clearly that with this group of patients chosen at random, that you saw real benefits from the technological revolution. And the UK is now rolling it out to the 3,000 people it sees as most vulnerable. And my third very simple story is the staffing revolution. If you think about those two stories, if you're monitoring people at home, and that's your normal way of having first contact with people, or if you are, if patients are doing things like perhaps delivering chemotherapy to themselves, certainly doing transfusions themselves, and so on, if they're doing all of those sort of things, then staff have to do things differently. But there's another revolution going on that we can see, where, for example, again, in my country, when I was chief executive, we introduced nurse prescribing very widely, against the opposition of some of the doctors, but because some of the individual doctors, of course, wanted it to happen very much. And we introduced it very carefully, went through all the processes, we managed it so carefully that now, 10 years on, this again is the norm. Nurses now prescribe a very significant number of common drugs in the UK. They only prescribe they've been trained to do it, and they only prescribe a limited range, but they are the most common drugs. And what's interesting about that as well is that not only has reduced costs, it's increased patient satisfaction, because perhaps it doesn't totally surprise us. Patients often prefer to deal with a nurse and to be able to ask questions and so on, than sometimes with the white-coated authority figure. Now, I raise all three of those things because they're very radical, they're very significant, and it's about the change that we are actually talking about here. This isn't about, as people have said, I think, all day, about just adding technology to what you do already. But if you do these three revolutions, you do the revolution of pushing it as far as possible as to what patients can do for themselves and what they want to do for themselves, and why treat me as a consumer? You know? Why aren't I a co-creator? Why aren't I actually responsible for my own health and helping you as a clinician to help me? Very different paradigm, very different way of thinking about it from where we normally are. And if we also recognise that we can train different members of staff to do different things in controlled ways, and there's masses of evidence for it, and we put that together with technology, you can make a real difference. And I think the challenge to this room, because I guess if you're in this room, you're here because you're a leader and interested in one of the movers and shakers in the IT industry or in the health industry here. And Dr. Ganapathy and colleagues have brought together a great range of people. And it seems to me the challenge that's faced here is to create that vision for what this really means in the future. We've heard a bit about a vision for e-health on a wider level in terms of the sort of mechanics in a way. What does it mean for the health service? What does it mean for what you actually do? And I'd produce those sort of 3 pointers. I think it means patients doing a lot of different things, behaving very differently. I think it means staff behaving very differently. And I think it means designing the technology to help make that happen. Thank you very much. And actually, executive of Unitech in New Zealand, as we've gone right around the world just about now. Dr. Eade has been the chief executive since April 2008. He holds a master's degree and a doctorate in chemistry from the University of Waikato. He's a member of the Australian Institute of Company Directors and chairperson of the Metro Group, comprising the 6 major institutes of technology in New Zealand, who work collaboratively to drive economic performance through provision of efficient and effective education. And we very much look forward to hearing what you have to say. Thank you.
Namaste. And as we say in the Maori language of New Zealand, kia ora. And as we say in the New Zealand European language of New Zealand, g'day. Look, thanks to the conference organisers for the opportunity to speak. And I'm very conscious that we're standing between you and your afternoon tea, so I'll try and keep this brief. What I have to talk about today, I think, sits in between the session we've just had and the previous session and tomorrow's session on health education. And I think it picks up the point I made, I think, quite frequently in our previous session about the importance of the training of the workforce in the interaction and the use of e-health. What I want to talk about are the implications for how we train the workforces of tomorrow in this face of such amazing change. Now, I'm going to declare that I am neither an ICT specialist nor a health specialist. I don't know whether it makes me qualified to speak on anything in this conference, but I am privileged to lead the largest provider of applied professional education in New Zealand, and we have one of the largest health schools focused on applied health and allied health roles such as nursing and medical imaging. And we've also got one of the largest IT schools in the country, focused on producing graduates that are employable in the ICT sector. And for my institution, the most important thing to me about what we do for our students is that they get a job as a result of their studies, and that when they go into that job, that they're productive immediately and adding value in the workplace, adding value to our future economies, our future societies. Now, like all chief executives, I try and spend a lot of my time looking out into the external environment, understanding how that external environment is changing. What does it mean for what we should be doing in terms of how we develop our curricula, develop our qualifications, and teach our students to make sure they're relevant not just for the jobs of today, but for the jobs of tomorrow. And it's very clear that in New Zealand and around the world, this disruptive or enabling or confounding role of technology is having a significant influence on the way in which we conceptualise how businesses and organisations work into the future. Big data, security, informatics, and so on. Now, the really interesting thing about the transformational nature of the role of technology is that both the health sector and the education sector, I would argue, are some of the sectors with the most ability to display amazing inertia in the face of change. And I think we heard some comments about that earlier on. Now, just reflect briefly on the health IT sector and health ICT sector in New Zealand. In fact, also in the health sector, the convergence between the two is increasing. New Zealand, as I'm sure you're aware, is a very small open economy. We're tucked away at the bottom of the world, 4.5 million people, about the same about the same land area as the UK or Japan. So we have low population density, but we have a GDP that is actually smaller than the turnover of most of the Fortune 50 companies. So a very small country, a long way away from everywhere. The role of technology is becoming increasingly important in our society. We have a high-performing education system, we have a high-performing health system, and we have an amazingly burgeoning health ICT sector, an industry that is a hidden gem in our country. Everyone knows about the agribusiness that we do, the dairy industry, but what few people know about is some of the incredibly innovative companies in the health ICT sector, or in the ICT sector in general. For example, Sir Peter Jackson's Weta Workshop was responsible for most of the digital animation behind the amazing Hobbit and Lord of the Rings movies. So the IT capability in New Zealand is quite astounding. Today we have next door an exhibition from New Zealand Trade and Enterprise that features a number of those health ICT companies like Orion Health, like Fisher & Paykel Healthcare. And I do encourage you to pop next door and have a chat to the friendly bunch of Kiwis who can talk to you about the amazing industry and the amazing opportunities that those companies can bring to your organisation. Now, one of the fundamental challenges that all ICT companies and IT companies are facing with their health or anything else in New Zealand, and I suspect this is similar in other countries, is the inability to attract enough skilled people into that industry to help them grow and develop their products and their companies. There's an incredible disconnect between what's happening in the school system and what the needs of the IT industry are in terms of accessing skilled young people. There's a real disconnect for teachers and even the school curriculum in terms of what the real jobs are in the ICT industry versus what the schools think those jobs are. If you talk to kids and parents about IT careers, they still think it means repairing computers or maybe being a Microsoft certified software developer. And no offence about either of those jobs, but the careers in the ICT sector are incredibly exciting, incredibly innovative, and yet that story is just not known to parents and to young people about what's possible. And so one of the things that we are focused on as an organisation is trying to better connect with the ICT industry right into the schools to help build that supply of people, even as at year 9, year 10, who are just thinking about the possibilities of a job in the IT industry into the future. If we now jump across to the health sector in New Zealand, and I think we as a fairly well-developed country are facing the same sorts of challenges that I've heard about already today. The fact that we have got an ageing population, increasing prevalence of obesity-related conditions coming from overnutrition, together with those amazing developments in clinical care and healthcare solutions, that means that the costs of healthcare are well outstripping the ability of the taxpayer or private insurers to fund the healthcare. So we have to find ways of either avoiding the problem of just building more hospitals, keeping people out of hospital in the first place, but if they have to go there, making sure that the system can attend to their needs in the most efficient way possible and deliver the great patient outcomes. Now, I think one of the other challenges, and again we heard about that today, is the traditionally siloed culture within the health system, within health providers. The many different professions that have to work together, each operating with their own little worldview, it just signals this incredibly, I think, challenging cultural transformation that we need to effect in the health system in New Zealand, and I'm sure that's the case around the world. And this transformation comes about through culture, through people, through process, through technology. We can't rely on any one of those things. And so what this means for an education provider is we have to think about what we can do in the way we go about training our graduates to get them thinking completely differently about how they interact with other people and other professions. Now, one of the things that's been going on in New Zealand is the creation of a national body called Health Workforce New Zealand, which is actually thinking about what are the jobs that the health sector needs into the future. What are the jobs and what are the new roles? What are the new scopes of practice? What are the new interdisciplinary or transdisciplinary jobs that help connect across the health system? And then starting to translate those down into qualifications and curricula that signal the way for the future of education and training. And that's a very important body, in my opinion, in terms of how we as providers need to think about shaping our curricula, shaping our graduates for the future. And to focus on much more cross-disciplinary and cross-functional roles. Next year, for example, my institution is taking all of the different healthcare majors and combining the first year of study into a single shared program. So instead of the nurses having physiology taught one way, the medical imaging people having physiology taught another way, and so on. It's about bringing all of these people together and all taught on a fully online environment for the first 6 months. We're trying to build digital literacies into those students from day one. The other thing we're working on doing is creating settings where people have to work across professional boundaries. And I'd like to finish by sharing with you a little practical example of what that looks like. I'm just wondering if you could put the video on, please. Thank you. It's set off playing. So this little video is a representation of a game that was created by a team of our students under the supervision of some of our faculty. Now, the interesting thing is that this game arose from a collaboration between some healthcare students, some computing students, some design students, and some performing arts students. And it's a game that's focused on 7 to 10-year-old children who've been newly diagnosed with type 1 diabetes. Using avatars and characters in the game, and this is available as a mobile app and on the desktop game, Young patients learn about their condition through in-game tutorials and in-game puzzles. To unlock new worlds in the game, they earn experience points by performing diabetes-related tasks, in which they gain experience points. These tasks are carried out in real time, and they get reminders about diet, medication, and other aspects of managing diabetes. The system develops a model of the child's behaviour habits, if you like, during this, and generates reports to the hospital and the parent. This team has been collaborating with the New Zealand National Children's Hospital diabetes team through the development process and clinical trials of the game to actually see if the changed behaviours that the game hopefully creates translate through into better health outcomes for those kids. So this was done by undergraduate students, and it is teaching them all of the soft skills about collaboration and working across professional boundaries. But the amazing thing is these undergraduate students have created a potentially quite relevant and quite viable application that will add real value for the lives of these kids. And that team that created the app ended up being national finalists in Microsoft's Imagine Cup, which is an international competition aimed at students in the ICT sector. So I think this sort of tries to sum it up in a nutshell about what the future of health-related education needs to look like for our future workforce. We are training people for the jobs of tomorrow, not the jobs of today and yesterday. We have to create the environments in which they experience highly technology-enabled learning, highly technology-enabled processes, and highly collaborative behaviour. And it's simple as that. And if we don't lead the change as what the new entrants into this workforce are equipped to do, then how are we going to actually affect that change that everybody needs for the healthcare system in the future to deliver those great outcomes for the patients of the future? Thank you, everybody.
It's in New Zealand, and also what is required for skill development. So now we have time for Q&A.
Have we got time for question and answer? Oh, the 1 minute video, okay.
Yeah, I think you can stop it now. All right, is there any questions from the floor?
I mean, out here. Yeah. Is there anybody who wants to ask a question or make a comment? Or
I'd like to know more about the opportunities that one of the presenters was mentioning in Latin America. Quite keen to know about what is the commonality of interest there.
Latin America is open for business. For example, Chile is by far the Latin American country that I say is the standard. It's the platinum. Chile is a very developed society. It's a member of the OECD. Colombia is joining the OECD. Chile, of course, the ring of fire like New Zealand. And if you wanted to do business, let's say in places like Barbados, you come to set up shop, you don't pay any taxes. Barbados has a 99.99% literacy rate, the same as in Guyana. That's one of the great things about the Caribbean. We have very high level of literacy. Everyone can read and write. In Costa Rica, it's another example. That's a good place where you've got a good pool of human capital. The same is in Chile. And more, the Inter-American Development Bank is spending money on rural education. In fact, Carlos Slim himself has a foundation that is spending a lot of money. So every day, many more people in Latin America are going to school. They're having access. One of the things I tell you, the Spanish were great at building churches and bringing horses, but they were bad at administrating their colonies. So you had generations of people who never had access to good education, but that's changing. If you want to open a business in Latin America, it's one of the easiest places to do business. There are no restrictions, perhaps maybe in Cuba, on the repatriation of your profits. I think what India offers and Latin America does not quite have, you have a lot more graduates, a lot more specialists. So if you were to invest your money, bring the equipment and the human capital transfer, you will be able to quickly assemble a core of dedicated, highly trainable, highly skilled, and highly effective people in these various countries. And in the long term, it will pay off handsome dividends. But as you know, as they say, the early bird catches the worm.
How does it compare with the Cayman Islands? I mean, you did mention in your
Yeah, the Cayman Islands is an offshore jurisdiction. It's a British overseas territories of Britain, like Bermuda, like Anguilla, like the Turks and Caicos and the British Virgin Islands. They've got some autonomy. I'll tell you an example. You might be the holder of a British passport, but you cannot turn up in the Cayman Islands or Bermuda and live and work. Oh no, you need local permission to do that. Cayman Islands is good for offshore banking and insurance. It does not have critical mass in terms of human capital. I can tell you a story, and Tata knows it well. They went into Uruguay thinking they're going to build this huge call center. And they could only recruit 300 people, and then they started advertising for doctors and lawyers to come into the IT field. It was a disaster. And they quickly shifted shop to Brazil. If you want to go to a place that has scale, you come to a place like Guyana. You've got 1 million people. Barbados could be your jurisdiction where you incorporate, but Guyana is where you find the skilled labor at reasonable cost. You go to Panama, where you've got skilled labor, reasonable cost, no taxes, based on a Dubai model. Colombia, beautiful country, great work ethic, very hardworking, very committed people. Or you could go to Chile, where you have skilled people, you've got critical mass, because these are going to be your centers of excellence. Don't try to do that in Argentina. The doctors may tango in the middle of the day, and the patients are just going to pass out. I can assure you of this. But the 4 countries, 5, will be Ghana, Barbados, Panama, Colombia, Chile. Brazil, that's a place, it's attractive, it's sexy, they want you to come and do business, but unless you have about 55 Brazilians working out of a team of 60, you can't do business. They make it very difficult. The Brazilian tax system, it's a labyrinthine, it's a maze. You need to have a degree in tax, being the artful dodger to deal with their tax regulations. And if I might add as well, and I'm seeing this a lot, people are leaving the US and going to places like Costa Rica for dental implants. They're going to Colombia for cosmetic surgery and breast augmentation. I mean, this whole sector is just ripe for the picking. But you gotta come now. Don't wait until next year.
Right, you've got your message very clearly. And we've got one more person. We've got 2 people now, so we'll take these last 2. Should we go to you again over this side, and then we'll come over to this side?
So I have a question at home, and then nurses doing a lot of the common kind of treatments. Would you venture some projections for what's the relative percentage of, I guess, cases that could be covered by these segments, let's say 5 years from now or in the longer term?
Well, I think, and it's a much more complicated picture, but everything I talked about will be resisted by somebody. And if we think about patients doing more for themselves, that's counter to how most of us have been trained, because actually we've been trained to serve people and to look after people and all the rest of it. And I think it will be quite a slow process for that to happen. I think it will start to happen, because interestingly, you've got this sort of dichotomy in the world. You've got developing, fast-growing nations like, I call the BRICS, actually, as we've heard about, who are starting to develop universal healthcare systems, and indeed Brazil has got a very good one. And then you've got in Europe, those of us with universal healthcare systems who are trying to hang on to them. And we're going to have to be innovative to hang on to them, because they're too expensive. And the reason they're too expensive, they're too hospital-based, They're too technology-based in an old-fashioned sense of technology. They're too physician-based. And those were the right solutions for the diseases of 50 years ago, but they're not the right solution for today's diseases. We need a change that's much more community-focused, much more people-focused. So it may be that we will see money driving some of these changes in Europe, and we will start to see the boundary shifting. And we will talk much more about co-production. You know, there's this bizarre expression of patient empowerment, and I'll finish on this one rather than try and give you another 10 minutes, of patient empowerment, which is very odd because actually we as patients empower our clinicians. It's always worth remembering, isn't it, that patients don't do what they're told. You know, sometimes people talk about it not conforming or some such top-down, aggressive sort of style language like that. But 30% of drugs aren't taken as doctors prescribe them. And we know that. You know, patients actually make their own decisions. They decide whether or not how they're feeling. So the only time that doesn't happen is if I happen to be in Chris's intensive care and completely out of it, then I will do what he tells me 100% of the time. You know? But as you feel better, patients tend not to do that. And that's actually what you're building on there. You know? Patients want to do more. There's a lot more motivation. And I think we'll be surprised about the areas in which more can happen. I can't give you a prediction, but I think it's a very big, significant movement. And I do notice that some of the commercial companies are starting to spot that this is one way of cost sharing, of cost shifting, get patients to do more. Now that's a purely economic example, but I think it's one of the great trends that we will see as diseases change. Let's take the last one.
My name is High Growth Rate Opportunities in Latin America, and we are trying and we have tried very hard to grow in Uruguay and Argentina. But what we have felt that there's a very high attrition rate, and when I say high attrition rate, it's even difficult to keep the people for 9 months. So how do we go for that?
Excuse me, I wonder if you could come up and speak from this microphone, because we're not hearing you properly, the sound.
To grow in Uruguay and Argentina, but the problem what we are facing is a very high attrition rate. And when I say high attrition rate, I mean that it's even difficult to get the people for even 9 months or a year. So how do we go there, establish business, and have this problem solved?
You're talking about your experience in Argentina?
Argentina and Uruguay.
Well, I talked about it earlier. I forewarn you. If you want to go to Argentina, learn the tango by all means, but it's not a place that, I'll tell you from experience, a friend of mine who worked for a major package company set up shop in Argentina, and the people who he hired to work for him, they were running the deals on the side through their relatives. Very unethical. Let me tell you, I'd rather take my chance with the Taliban than take it with the Argentine government, because they are a very difficult group. They will steal from you in the middle of the night, and before you know it, you're penniless. No disrespect to Argentina, but I would not put a single penny there. You go to Chile, you go to Guyana, you go to Colombia, you go to Panama, you go to Barbados. They will welcome you, they will work with you. You're creating jobs. You're bringing intellectual capital. You're transferring technology. You know, you cannot put a dollar value on the health of someone. And when, you know, Latin Americans are a lot like Indians. They look at relationships very sacredly, with the exception of Argentina, which marches to its own beat. You know, you come there to do business, and people see, look, you're making a contribution to the long-term health and development of their country. They consider it an honor to work with an Indian. Indians are respected in Latin America for their cerebral prowess, for their brilliance, for their achievement, for their mind power. Every person in Latin America you meet will ask you about Gandhi or Deepak Chopra. Believe you me, you've had such an impact. Even in Brazil, they've got these Indian telenovelas. But I will clearly say, steer clear of Argentina. Go there at your own peril, but don't say I didn't warn you.
As it happens, we have the ambassador from Argentina in the audience who would like a report.
Raised the question, and I think it was contradictory in nature. And I work from Dubai for the telecom operator out there, and I kind of understand the non-communicable diseases and chronic disease prevalence in that sector. Stephen mentioned that Saudi Arabia is building 145 probably tertiary level hospitals, whereas you raised a very important point about how today's diseases are actually not probably meant to be treated in hospitals of that nature, need to be more community oriented and home oriented. So there seems to be a huge dichotomy or a paradox out here, whereas the regions which are suffering so heavily with the problems we are talking about are actually building something completely irrelevant probably. So any comment on that?
And make another comment. I think it's very easy for me in the UK to say we've got too many hospitals and we need to get much more focused on the community. But we have got the hospitals. Whereas actually I spend most of my time these days working in Africa, and Africa needs a lot of hospitals. It also needs the community development as well. I don't know the position in Saudi Arabia, so I don't know to what extent you still need hospitals. It's not that you don't need hospitals, but you don't need a system that is so focused on hospitals. And it may be that the Saudis are also doing quite a lot about community development as well, as well. And certainly that's the situation in Africa, where one has to recognise that the biggest gains are going to be, as they will be in rural India, at the very local level, but you still need the very highest standards and abilities that you have as well. So, but you know Arabia, and I don't, so let me pass to you.
I think from my perspective, I think when politicians look at the needs, they look at a couple of areas, right? One is really a social needs in terms of whether the aging population are coming out, how do I actually ensure that their needs. The other point is also political needs, where you want to make sure that you stabilize, okay, the country in terms of the different groups. You want to ensure there are equal delivery of healthcare across a country. So look into that perspective. I think likewise, even in Singapore, like a small country as Singapore, we are still building hospitals. But however, just building hospitals, whether in Saudi, in Qatar, or in Singapore, and other countries, is just not good enough, because as what I think a lot of things have been alluded in this morning discussion is that you need to make sure that you have the right staff, you make sure that you need to have the right system, you also need to make sure that you have right training as well, right, that comes in. So when Saudi are doing that plan, actually they are trying to do all these things at the same time. So there are areas that I'm helping them in terms of training, getting to ensure they understand what standard is all about, what are the things that need to put in place, what are the ICD-10 that need to be taught to make sure that they build the skill set, the skill development of the people there, whether is it the local or the aspect that is going into that country. So I think when we actually look at that, we need to look at the holistic level. All right? I think with that, I think this is a good discussion. I think you hear a lot of the developments in each of the countries and areas around the world. And we'll be around the rest of the evening. If there's any other questions that you need to approach us, you actually can approach us later as well. All right, thank you very much.
Well, the whole dialogue and debate did make justice to the interaction session. Well, I would request our chairpersons to please. Session at hall number 4, and before that I would request everybody to please join us for tea at the Trade Exhibition Center, please.